Hello, everyone, and welcome to this webinar series, the first in the series of TrialX Space Health webinar, where we will be exploring technological advances, shaping space health, and cutting-edge research aimed at astronaut well-being in space. Today, we are discussing how imaging in space is rewriting remote diagnostics. As more and more commercial space flights are taking off and more civilians are heading into space now, we are starting to see the limitations of Earth-dependent imaging, given how microgravity changes our bodies, how communication delays is making real-time radiologist guidance almost impossible, and bandwidth limits slow down data transfer. And also the fact that crews actually don't have specialist training most of the time. All of this is pushing us to move beyond portable devices towards imaging systems that can work autonomously, fully on their own in space. So today we'll be taking a look at what it really takes for imaging to work in places like with high-risk environments and zero connectivity, and how these same capabilities can improve remote and decentralized care back here on Earth. I'll quickly introduce our speakers in the panel today. We have Abigail Watson, advanced informatics consultant at TrialX with 20 years of experience across hospitals, federal labs, and aerospace medicine, including work with the FAA Office of Aerospace Medicine. We have Syed Gufran Ahmed, solutions architect for space EHR systems, specializing in AI, LLMs, and cloud-native automation for spaceflight participant health systems. And we have Vadat Jan, medical informatics engineer, developing real-time clinical data and device integration systems for spaceflight with AI. So thank you, Abby, Gufran, and Vadat for joining the panel today. Before we begin and dive into the discussions, just a bit about the logistics of the webinar. Please set up your video settings at 720 pixels so that you get the best audio and video quality throughout this webinar. And we will be having a 10-minute Q&A session at the end of the webinar, but feel free to put your questions in the chat box. We are also live streaming this on YouTube, so you can add your questions there as well as you're watching. Thank you again, everybody, for joining, and I will let the panel take it away. Gufran, over to you.
Yeah. Thanks, Shweta, for that introduction. So today we will talk about space medicine and how it's not a thought experiment anymore, and how extreme environments are helping in testing devices and protocols for space missions. To solve the problem of space, we often look to the extremes of the Earth. Space agencies have long used harsh terrestrial environments as analogs to simulate space missions. These environments allow us to test medical equipments, validate clinical protocols, and train crew under conditions that closely resemble space. So the Antarctica as the highest fidelity space analog, Antarctica is considered the closest space analog on Earth. Crew members there are isolated up to 9 months with no evacuation capability. Like astronauts, they work in dangerous environments, depend on entirely on technology for survival, and experience extreme physiological and psychological stress. And the parallels between polar and space missions are profound. Both Antarctica and space mission involves isolation, confinement, hazardous environment, complete dependence on technology, limited evacuation, and autonomous operations. The main difference in the between Antarctica and space is that Antarctica has gravity and protection from space radiation, while space does not have that.
Thank you, Gufran, for that introduction. So when thinking about missions at McMurdo Base and other areas at in the Antarctic, the thing to keep in mind is that every kilogram that is of equipment that is transported there is costly. It's costly in terms of coordination, logistics, fuel, effort, and most people don't know it, but it the costs to get equipment to Antarctica average between $20 and $100 per kilogram when it's airlifted by plane or by helicopter. And it gets even worse when sending equipment into orbit. Traditionally, in the Apollo era, cost of equipment into orbit averaged $14,000 per kilogram. The shuttle era was even more at nearly 18,000. And although recent efforts by SpaceX with reusable rockets is lowering that cost down to just under $3,000 per kilogram, the cost to send heavy equipment like MRI scanners and CT scanners is still going to be in the millions of dollars per equipment. And so a great care needs to be thought about which equipment is going to be sent to which mission. Next slide, please. Now, traditionally in a hospital setting, you have two departments that are responsible for the bulk of diagnostic testing, and that's usually laboratory and radiology. Laboratory has a number of modalities which are fairly portable, then can kind of be put into an EMT kit or something. You have portable hematology kits or maybe point of care testing, portable lab microscopes and molecular diagnostic equipment. That kind of stuff can be transported relatively easy. The bigger stuff like a blood bank or anatomic pathology center, they're going to have like refrigeration cabinets and morgue tables and stuff. And we're not going to see that kind of equipment get into space missions for quite some time. Now then, on the radiology side, it's a similar issue. Big equipment like MRI and CT scanners are going to be prohibitively difficult to get into orbit in general and on space missions due to a number of factors. The mass, they also have power constraints, they draw heavy amounts of power. The MRI scanners create a magnetic field around them that's difficult. And the CT scanners, a lot of people don't realize it, but they actually have a moving part in it that spins. And so that's going to create rotational wobble in your rocket or your space station. Similarly, nuclear medicine can be big and bulky, and it has radioisotopes that you have to transport around. So all of those modalities aren't good candidates for diagnostics on space missions. However, modalities like portable X-ray and ultrasound start having the right cost, mass, benefit, power dynamics or cost-benefit analysis to make them worth looking into. Your portable X-ray is still going to have some radiation and isotopes that you have to transport around, cobalt cores that generate the X-rays. But the modality that is really starting to interest people is portable ultrasound. It's really got a lot of benefits in terms of versatility, portability, no radiation requirements, and the kind of thing that could be put into airplanes, rockets, space stations, and so forth. So next slide.
Yeah, Abby, I am just curious, like, does MRI scan has an effect from the magnetic interference?
Well, so it's going to create like a big magnetic field around it, and you can put some shielding to prevent that magnetic field from going to other parts of a station. We'll probably see if and when MRI ever gets into orbits or space stations, we'll probably see them have their have a dedicated module or that's just the MRI module, and it'll be kind of self-contained, not unlike how we do mobile MRI clinics, maybe in the Southwest, or radiologists will put an MRI scanner in a back of a semi truck and move it around. So we'll need to at a very minimum have a dedicated module for it.
Yes.
Next slide. So ultrasound in space is not new, actually. It's been around for at least 15 years. And one of the first real studies on it was on the International Space Station, starting in 2009 or so, with the Advanced Diagnostic Ultrasound and Microgravity Project, sometimes called ADUM. It was sponsored by Henry Ford Health System and Weill Laboratories. And in this photo here, you can see the blue device is it. They send up a hospital-grade device, but they sort of made it rugged, and they put it into a kind of a briefcase design. And so that blue box, the double blue box, is what you're looking at. Let's see here. Next slide, please. Let's see here. Okay. So the results from this study were positive mostly all around. ISS crew members were able to successfully perform diagnostic quality ultrasound exams. So they were able to use the equipment with minimal training and guidance. They were able to pick it up. They were able to effectively use it on day-to-day procedures. There aren't a lot of accidents on the space station, but people have cuts and bruises, and they get nauseous, and there is kind of routine stuff that they deal with. So they were able to use the equipment for day-to-day needs. They were able to do so with visual aids and procedures. And it's very common for astronauts to have sort of flashcards, or they're not quite cheat sheets, but they're one-page summaries of here's recipes. So they had visual aids and procedures, and they would also call down to mission control and consult with the flight surgeon on call. The one particular thing that happens in the space station was astronauts tend to get swollen eyes from this ocular syndrome. It's related to microgravity. So they did these eye examinations, which we'll talk about later. Generally speaking, the ADAM project came away with it supports full use of ultrasound in space exploration moving forward. So next slide. For those people who wish to learn more, we have some citations in here that you can get in the slides after the talk.
Abby, if I'm not wrong, the picture on the right-hand side shows the scan of the eye, right?
That's exactly what's happening. So you can see in the photo an ocular exam with the ultrasound. This is a pretty, as far as ultrasound exams go, this one is delicate. It's the angles, and it's an advanced image as far as ultrasound imaging goes. Not the easiest to do, and they had to position the person, keep them stable. Lots of detail with this particular procedure. Next slide.
Increasing global quality of life is also an area of research for Dr. Scott Dolchowski, Chief of Surgery at Henry Ford Hospital in Detroit. Dr. Dolchowski's team developed just-in-time training for astronauts to use portable ultrasound on orbit. That training has translated to treatment in underdeveloped areas of the world.
This is a wonderful tool to enable a very minimally trained individual to provide some really critical medical information in a really time-sensitive manner. And I guess it's not a big step to start thinking about How do we provide medical care in somewhere like Brazil, where we're in right now, where you got really difficult problems that you're not going to get a doctor to?
In 3 years of research, Dr. Dolchovsky's team has diagnosed and treated more than 40,000 patients in underserved countries with portable ultrasound.
What is the worth of going into an underserved area and telling a mom, you know, this pregnancy that you have this child where you are right now, you'll die, as would the child. But with these really simple, very cost-effective things, and that we learn and develop, I can tell her, start walking 4 days to a higher level of care, and you'll be fine. And that's worth something.
That same line of study uncovered conditions that could be diagnosed through portable ultrasound rather than through traditional techniques, including collapsed lungs and broken bones.
We do worry about a lot of health conditions. Got a list over 500 of them. And we started to think that maybe 2/3 of those we could get some information with ultrasound, but that had never been done before.
Spinal ultrasounds are currently being used aboard ISS to study how the body is affected in microgravity and how that might translate to treatments on Earth.
Thinking very broadly beyond just being explorers in that and fulfilling that. The Earth benefits, the spin-offs, have been enormous.
Now, as we think about what the usage of ultrasound is in the diagnostic setting, as the professor or the doctor mentioned, there's like 500 exams that you can do with ultrasound. By frequencies, one of the largest categories is going to be OBGYN and sexual health. Maybe we'll get there someday in orbit, but that's not the near-term usage. Near term, we're going to see a lot more emergency medicine usage. And by frequency, you're going to be talking about abdominal ultrasound, carotid, cardiovascular, and maybe that musculoskeletal that the doctor mentioned. Microgravity environments also have these fluid retention issues. And in orbit, we have this neuroocular syndrome that many astronauts experience. And that's going to be one of the frequent usages as well. More on that in a bit. Next slide.
So, when you are in space, there are physiological shifts that breaks the traditional imaging when you are in space. So, we have to think why space forces us to rethink healthcare completely. Like there is fluid redistribution happening in space, there is muscle and bone loss happening, there is neuroocular changes happening when you're in space, there is cardiovascular dynamics happening to your heart, there is altered hemodynamics, complicates the Doppler assessments that requires adaptive AI models to evaluate how the SFE is doing in space. And also the environmental factors complicate the imaging physics, like acoustic coupling is happening and there is vibration artifacts. Spacecraft system introduces motion artifacts that requires advanced filtering and frame selection algorithms to make a clean image out of the scans. And there is power constraints, and then there is the cabin volume. The cabin has the astronauts have restricted movement while they are in the cabin, and it affects the scanning ergonomics and requires compact probe geometrics. So the ultimate test case is the Inspiration 4 mission. In September 2021, I-4 mission was launched the first all-civilian crew into the orbit. This provided an unprecedented opportunity to move from analog to application. The critical question that this mission answered was, could a non-professional crew using only just-in-time instruction and Earth-tested hardware successfully perform autonomous medical research and data collection in space? So the in-flight experiments were autonomous ultrasounds in orbit. They were provided an ultrasound probe and an iPad, and we can point out, like Abby showed earlier, we showed that a huge briefcase for doing a scan, and only after a decade, and we are seeing a very small tablet and a very small handheld portable device connected to a display, and they are able to do scans effortlessly there. So the crew were provided preloaded just-in-time instruction manuals on a tablet, and there were no real-time guidance from the earth. They had to perform scans for urinary bladder and internal jugular vein, and eye scans for detecting the space-associated neuroocular syndrome. Guidance from the
Thanks, Fran. So a couple of findings here, like the feasibility is a function of procedural complexity. So up to this point, everything what have been shown sets up one uncomfortable truth, and that is autonomy in medicine is not binary, it's conditional. So on Inspiration 4, as Gufran was talking about, that civilian crew members performed ultrasound scans using just-in-time instructions. So there were no real-time help, no experts watching, and the results were scored objectively on a 0 to 3 quality scale, as you can see on the screen, with 2 as the minimum usable threshold. So what basically worked here, bladder scans, jugular vein scans, and the both cleared the usability bar comfortably. And what didn't work is the ocular imaging, and it failed to meet the threshold. This matters here because it tells us that autonomy breaks first at the procedural complexity, not at the crew motivation or the hardware quality. So this takeaway is this, like simple to moderate procedures are already deployable today, and complex procedures demand either specialized operators or machine guidance. Next slide. There was another finding, like no early signs of jugular vein thrombosis, and like one of the biggest red flags from the long duration ISS missions has been abnormal jugular vein flow, which includes stasis, reversal, and thrombosis. And this is not a minor issue. This is a deep space showstopper if it happens early. So Inspiration 4 gave us a clean experiment here, like there were zero signs of abnormal jugular flow, there were no reversal or no thrombosis. This tells us something critical here, like these pathological changes are likely time dependent, not inevitable. So they appear over weeks, not days. Next slide. So before moving on, I want to ground all of this into something concrete. So we'll be showing a demo. And in this demo, we are using the same butterfly ultrasound probe that flew on the Inspiration 4 mission. And this is not a lab prototype and not the new hardware, it's flight-proven equipment. Like during Inspiration 4, the crew followed the just-in-time instructions to perform vascular imaging. We have already tested this butterfly probe on an iPad, which mirrors the tablet-based setup used in the orbit. What we are showing today goes one step further, the same probe and workflow running on a Windows machine. So can you play?
Today, we are going to perform an ultrasound using this butterfly device on a Windows system. So we are going to perform an ultrasound for carotid artery in the neck of the patient called Wahadat. We have an ultrasound on him, and on the screen you can see a Windows system on which we are connecting this butterfly device via the USB cable, and it can run in an offline mode. So starting the ultrasound, so I will be taking this ultrasound gel and would be putting this on the device. I am going to perform the ultrasound of the carotid artery in the neck. The test uses sound waves, so there is no radiation and it's completely safe. And the purpose of the scan is to check the blood flow in the main arteries of the neck and to look for any narrowing or plaque buildup or any abnormalities. So I've selected the preset and I will click on the start. And it has started. Now weighing the patient. So I am, as you can see, the bigger opening that you're seeing is for the jugular vein, and beside that is the carotid artery. And if I press more, you can see it's a tricky scan for the carotid artery. If you press more, that carotid artery shrinks. So you have to be very precise while doing a scan of the carotid artery. So you don't have to press too much. You have to put gentle pressure, and you can see the carotid artery is completely fine of the patient. And that was a very good scan. And on the screen, you are seeing the interface for the butterfly probe that is connected via cable to a Windows system. There are various modes by which you can see. There are various presets available, and here you can see the device.
Next slide. Operational constraints make Earth-dependent workflows impossible. Now, let's talk about why our current health workflow simply don't survive outside low orbit. Let's talk about the latency here. If we talk about at Mars distance, a one-way signal can take up to 22 minutes. So real-time guidance is fantasy here. We can talk about the bandwidth. We cannot stream raw DICOM files or high frame rate studies from deep space. So the radiation can damage the sensors, the electronics fail, and software must correct itself. And let's talk about the crew variability here. Astronauts are basically, they can be engineers, pilots, or scientists, so they are not sonographers. So if we put this all together and the conclusion is unavoidable, like any diagnostic system that depends on Earth fails by design, and portability alone is not enough. Connectivity alone is not enough. Next slide. So space medicine is the template for global remote care. This is where the conversation stops about being astronauts. So space produces the harshest healthcare conditions imaginable, like there are no infra, unreliable connectivity, minimal training, and zero margin for error. What it turns out to look like, it can turn out to look like a disaster zones, rural health systems, humanitarian medicines, and the decentralized clinical trials. So if your diagnostic stack works in orbit, it will work anywhere. Thanks.
So for this next section of our presentation, we're going to be talking about some of the data networking of getting from the image to the medical record. Traditionally, we've used a protocol in radiology called DICOM, which is known for digital imaging and communications in medicine. But the future of where this technology is going is likely to be with a technology called FHIR, Fast Healthcare Interoperability Resources. And the best way to explain this is FHIR is essentially a web protocol. So it's the same thing that web browsers use every day. But we're interested in, well, if you've flown on an airplane and had your tablet or your phone in airplane mode, we're talking about web applications that are in airplane mode. So we're thinking about applications and digital imaging that's actually offline first, and that has this delayed synchronization. So it can be it can be offline, take the images, do the processing on board, and do the automated detection, the computer-aided diagnostics on board in airplane mode before it's transmitted or synchronized elsewhere. This is different than the older applications that weren't network-centric to begin with. These are network-centric applications and technologies, but they can sort of turn on and off their networking. Next slide. This emerging protocol, which we believe is going to become widespread in both imaging and medical records and throughout the industry, has many data schemas for the entire clinical workflow. It was originally designed as a protocol for hospitals. And there's a number of like infrastructure data schemas or resources that are available, such as patients and encounters and questionnaires and so forth. But then in the imaging workflow, you have kind of two major parts to the workflow. You have the image acquisition portion, which is sometimes known as the technical portion, which is done by radiology technologists. And then you have the diagnostic, or what's sometimes known as a professional component. And so your technical component, the imaging acquisition, is going to have devices and procedures and body structure, imaging studies, document references, and so forth. Whereas the professional component, the diagnostic, is going to have a diagnostic report, maybe a composition and some measure reports for things like quality control. Next slide, please. Now, the way that we kind of structure this is we have three different APIs that we're application programming interfaces that we're using. We have a software development kit that the device uses. We have DICOM, which is the imaging component, and then we have FHIR, which is basically the medical record. So the SDK writes to the local client. That goes to something called a C store at the PACS system, picture archiving system. We may or may not use DICOM Web to do operations on the PACS. It might not be a full PACS system, but maybe a mini PACS running on the local client. And then as we process the study, that gets translated, that one DICOM study gets translated into a number of FHIR resources. So there's going to be patient, device, imaging study, procedure, questionnaire, and then maybe a diagnostic report attached to that separate, like as a next step. And then once it's in the FHIR spec, then it translates to all the subsequent downstream electronic health records, personal health records, and other systems that may be interested in using it. Next slide. The Trial SpaceX has been working on the Hermes project. It's built for zero connectivity and maximum reliability. It's a cross-platform device that works on Windows, Ubuntu, mobile devices, and that handles automated ingestion, quality control, metadata. And it's really been designed with these space flights in mind, and specifically for remote offline usage. Next slide. Now then, imaging shouldn't just be portable. It also needs to be autonomous. And by autonomous, we mean it needs to have that independence so that you can not just take it to a field location, but that you can use it and get the results there without having to take everything or consult back with home base. So next slide. Now, when we think about autonomy with the ultrasound equipment and we think about on-device artificial intelligence, we're talking about a number of different categories. We're talking probe navigation, which means kind of getting the probe in the right position. Then real-time quality assurance. Is the probe at the right angle? Is it tuned? You can kind of tune the depth of how close or far away it's looking at. And then as that image comes in, there's going to be different artifacts. There's going to be fuzz, there's going to be echoes, and you kind of have to, like a camera, you have to kind of get it into focus, and you sometimes need to detect what kind of artifact is going on. Why is it this kind of fuzz or that kind of echo? And then once the image is in focus, you then want to do things like anatomy labeling and segmentation and measurements, and you kind of want to apply knowledge on top of the image, and you want to take it from data to knowledge. Next slide. So computer-aided diagnostics aren't new. They've actually been around for decades now. One of the earlier pioneers in this area was the University of Chicago. And on the screen here, we have some images from one of the earlier ultrasound computer-aided diagnostics or systems that were produced. And so the first step in these AI systems is that you have sort of a library of image textures and patterns. And in the lingo, they're hyperechoic or hypoechoic or anechoic. And these things are talking about how much do different things produce an echo. And generally speaking, this falls according to bone, air, or water tissue. Throughout medical imaging, the differences in our tissues in our bodies produce different imaging artifacts, and oftentimes air, water content, or bone content are the first tissue detection types that these algorithms focus on separating. So in the middle of our screen, we have a kind of a decision tree that's kind of separating out, kind of bone, air, water content. And then in the third screen, you use that knowledge that algorithm to start doing segmentation. And you're kind of circulating like, oh, well, here's a blood vessel, or here's some lung. And it's kind of difficult to read, but there's kind of like a drawn outline around the anatomy segment that is overlaid on the image, and you get a full sort of algorithmic pipeline of parsing the image into its parts and then labeling it and detecting which tissues are which. With this, you can start providing automated diagnostics. Next slide, please. So as we think about autonomous diagnostics and where things are going next in space, we're really talking about on-device diagnostics where we might not have Earth-based clinicians available, on the phone. We're also talking about multimodal models, such that they combine ultrasound, spectroscopy, sensors with the large language models that everyone's talking about. And then finally, context-aware diagnoses. So the AI adjusted to the mission constraints and using the medical records. So maybe the device actually knows that it's in a microgravity environment, and that all of the diagnostics needs to take into account that there's going to be different types of fluid retention in the body. So the future of AI and ultrasound, we believe, is going to include all of these components. And yeah, next slide. So we're wrapping up. We've gone a little faster than our dry runs, but that gives us time for Q&A at the end. But for the call to actions here, so ultrasound represents one of the best mixes of weight, portability, cost, diagnostic function. It's been in use in microgravity environments for 15 years, and it has a proven track record for usability by a motivated crew. It's got teleradiology flows for when communication lags are short, but it's also got possibilities for computer-aided diagnostics for the longer duration missions. Next slide. Traditionally, images have been stored and transferred with the DICOM standard, but we see emerging patterns with FHIR and fast healthcare interoperability resources. We're going to see a lot more AI integration with these new protocols. And generally speaking, if I were to give a call to action or a takeaway from this message, it would be that EMT kits that are installed in aerospace vehicles, rockets, spaceships, but also here on Earth, like on yachts or on missions to Antarctica, they're ready for portable ultrasound to be added. Portable ultrasound is a cost-effective and useful piece of equipment that people should be giving thought to including in those EMT kits that will be traveling with expedition explorers to remote locations, be they Antarctica or the jungles of Brazil or the deserts of the American Southwest. Next slide. So we want to thank everybody for attending this webinar. Please reach out, follow us on LinkedIn and Reddit. We'll be opening the floor up to questions in just a bit. We will be having additional webinars come Q1 of next year. We're exploring the possibility of an HO7 aerospace medicine work group, which we encourage people to reach out and talk with us about. For more information on the Hermes project and joining or getting involved with Hermes itself, reach out to info@trialx.com. One more slide. Next slide. Quick acknowledgments to NASA, Baylor University, and the Translational Research Institute for Space Health, TRISH, that funded much of the Hermes project. Also to MITRE and the CMS Alliance for Modernizing Healthcare and the Center for Advanced Aviation Systems Development and HO7 for their support in developing the HO7 Aerospace Medicine Implementation Guide. Also, a big thank you to Butterfly, which provided the ultrasound equipment. And at that point, I'm going to open it up to questions. And thank you so much.
Thank you. Thanks, Abby, Gufran, and Vahadat. Quite an interesting discussion and presentation. Thank you for sharing all that information. We have a couple of questions showing up. I'll start reading out that for you guys. The first one says, are the data captured with the equipment in space shared immediately after with Earth, like within hours, or does it get transmitted after the space trip is over and people and hardware are back on Earth?
No, I think it's a little bit of both. It's not going to transmit immediately. I mean, I don't know of any of the ISS systems that auto route DICOM imaging. What I believe is the state of the art, or what my understanding is that it stores locally, and then if there's an emergency and they need to do a teleconsult, they have to basically open up the there's there's like a radio link that they that's constantly communicating between mission control and the International Space Station, and they have to they allocate that bandwidth for, usually it's like videos of maybe astronauts doing spacewalks, or but it's a network link, and they just have to prioritize the DICOM medical imaging traffic over other content such as telemetry or station keeping ops or video channels. And so when they want to use the main link, the main comms link for digital imaging, for medical imaging, they can't use it for other activities. And those big files might, tie up the main link for 20 minutes or however long. And it gets worse the further out the vehicle is. So on the moon or Mars, that main link back home becomes ever more tied up with the bigger the file is. Now then, once they come back home via personal health record or maybe a vehicle flight recorder or EHR to EHR sync up, then they could also do like end of mission dump of all the things that happened during the during the mission. So the answer is really both, but it's just not going to be an automatic relay. I don't think that's in the cards in most any situation.
All right. Thank you, Abby. Next question is asking, I'm curious about some other modalities, example, electrocardiogram, where there's also small, lightweight equipment and a good bit of automated and even AI diagnostics. Have those been considered in space for space work?
To my knowledge, so ECGs have been around since the earliest days. They are, there was, if you look at the diagrams of the Apollo Mission Control Center, there was a dedicated surgeon console that was completely dedicated to monitoring ECG monitoring. Now then, that's very voluminous. People like, because it's real time, and if you just leave the monitor on like 24/7, that data can really grow. And so there's this real trade-off with ECG data on like how much a lot of it is it's very baseline, and the signal isn't, if it's just normal, if it's just a heartbeat, it doesn't give you a lot of signal. It's only when there's like a heart attack or the signal stops that you understand that the heartbeat has stopped. So it's kind of like low signal until it's not. Until it's very important. And so I think electrocardiogram and ECG tracking is there's been quite a bit of study since the earliest days of Apollo, but at the same time, there's like storage and how much data, what kind of summaries do you want to use, and the usage of watches, smart watches, is a very active area of research from my understanding.
Thanks, Abby. The next one asks, when and why would you use ultrasound on the eye?
When you go in space, so there are morphological changes happening to your eye. So when you are in zero gravity, there is no gravity, there is a fluid dynamics happening in your eye, and it changes the shape of your eye, and which creates the pressure on the nerve of the eye. It even increases the pressure on that optic nerve on your eye. So that is why we have to perform the scan of the eye regularly for the patient, so there is no ocular pressure happening on the eye.
All right. Thank you. Thanks, Gufran. The next one is asking, I am curious which LLM AI we have used so far in space and what was the problems or issues faced with that, if any?
Officially, I don't think there is any LLM models deployed in space. What has been used, maybe a role-based system or a signal processing AI or computer vision models, like Abby explained, like simple image processing happening on an image. That is, but officially there is no LLM model deployed. Why? Because it requires high computation power, and also even 1% of hallucination would means it is not fit for space.
Yeah, I'm going to second that. Is the within the imaging realm, the CAD or computer-aided diagnostics is sold as kind of like a separate module, and to at least our understanding, there hasn't been purchase equipment for that and sent to the International Space Station yet. At least not. At least it's not been in public reports that we're aware of. And also we'll probably see LLMs in the near future, but not quite yet. So.
Yeah, thank you for that. And I think there is one more question asking, I'm sure we are looking at AI assistants for interpreting USG images in space. Are we looking at AI assisting astronauts in interpreting USG images? That's the question.
Definitely, we obviously, when we are thinking of long duration missions to Mars, where there is limited connectivity to Earth, we would require an AI assistant or a AI doctor who would be helping the astronauts if they experience any issues, or even assisting them in or guiding them for performing ultrasound while they are in space in isolation where there is no connectivity. So definitely we would, it is a requirement. It's not a thought process anymore, a thought experiment anymore. Like it's a requirement for future.
Okay, and I believe that's the last one that I see on my screen right now is what is TrialX actually doing with the data that is being collected from all the space missions? And how is it going to be used by researchers?
So TrialX is just hosting the data for these space missions, and we are providing these data to the researchers so that they can perform these research on those data and provide insights. Like one of the insights that we showed earlier was regarding the scans, how good the scans were performed by the astronauts, civilian astronauts, by just following the just-in-time training. And it was the result of the publication. The link of the publication is also available in the slide as well. Yeah.
All right. I think those are the questions that we had. I believe we can now wrap up the webinar, and thank you again for sharing all the information you all three, Abigail and Vadat and Gufran, and thank you for answering the questions. And as we wrap up, one thing was made clear today, that space is not just reshaping where we are delivering healthcare, but also how we are designing it. And at TrialX, we are definitely proud and super excited to be contributing to this frontier, building systems that enable clinical research on Earth as well as in space. So thank you, everybody, for joining today. And thank you for your questions and your curiosity in advancing medicine beyond Earth. We invite you to continue to talk to our speakers here on the webinar today, connect with them, and explore collaboration opportunities. Or reach out to us to learn about how we are supporting space health and how we can support your studies, remote diagnostic initiatives and on. We also look forward to joining us in January for our next webinar, like Abby has mentioned. And we will be talking about Artemis 3 mission and how we will be analyzing it through Hermes. So thank you everybody again, and we will be making this webinar video available on TrialX website soon. So thank you everybody. Until next time.
Thank you.
Bye-bye.